The lifted up apex, core and sabot, peasant's boot-shaped heart, due to the right ventricular hypertrophy, is seen well in this chest X-ray PA view. The right-sided aortic arch is seen indenting the tracheal air column on the right side. There is mild cardiomegaly and right atrial enlargement as well in this adult person with tetralogy of Fallot and associated inferior wall myocardial infarction. The lung fields are oligemic due to the right ventricular outflow tract obstruction in tetralogy of Fallot. Tetralogy of Fallot is the commonest cause of right aortic arch in an adult. Usually, the murmur originating from right ventricular outflow tract in tetralogy of Fallot is short if there is severe cyanosis, as the flow across RVOT is less, as the blood gets preferentially shunted across the ventricular septal defect into the aorta. Long systolic murmur with severe cyanosis in tetralogy of Fallot can occur with 1. TOF with absent pulmonary valve. 2. Restrictive VST. Long murmur due to tricuspid regurgitation as the right ventricular pressure may go suprasystemic. 3. AV canal defect. Long murmur due to AV wall regurgitation. Color Doppler echocardiogram in tetralogy of Fallot. Parasternal long axis view shows ventricular septal defect and aortic override. RV right ventricle, IVS interventricular septum, AO aorta, AML anterior mitral leaflet, LV left ventricle, LA left atrium, VST ventricular septal defect. Right ventricular free wall is hypertrophied. Color flow mapping shows blue colored flow from the right ventricle across the ventricular septal defect into the overriding aorta. This is the right-left shunt characteristic of tetralogy of Fallot. Another view had shown right ventricular outflow tract gradient suggestive of infundibular obstruction. Apical 5-chamber view in tetralogy of Fallot demonstrating the subaortic ventricular septal defect with aortic override. 50% of the aorta is committed to the left ventricle, while the remaining half is committed to the right ventricle. The VST in tetralogy of Fallot is a malalignment VST, which results from the malalignment of the ventricular septum with respect to the aorticopulmonary septum during embryonic development. The shift of the aorticopulmonary septum towards the pulmonary side produces both the ventricular septal defect and the narrowing of the right ventricular outflow tract. Van Praag and colleagues hypothesized that all the features of tetralogy of Fallot are due to the underdevelopment of the infundibular septum and its sequelae. They termed this as a monology, called by others as Van Praag's monology of Fallot. Apical 5-chamber view in tetralogy of Fallot with color flow mapping in systole with right to left shunt across the ventricular septal defect. Blue stream moving from the right ventricle across the VST to the aorta is clearly visualized in this frame. There is also a blue stream from the left ventricle to the aorta. Color flow imaging shows high velocity jet in the pulmonary artery arising distally from the descending aorta, suggesting a patent ductus arteriosus. This is one of the compensatory mechanisms to improve pulmonary flow in tetralogy of Fallot. Another mechanism is major aortopulmonary collateral arteries or MAPCA. Intrapulmonary collaterals can also occur in tetralogy of Fallot. The image is in the parasternal short axis view. Continuous wave Doppler interrogation of the jet guided by color flow mapping picks up the continuous flow with a peak gradient of 61.5 mm of mercury. The gradient is calculated from the velocity measured by the device using the formula P equal to 4V squared. Findings to be sought in an aortogram in tetralogy of Fallot are aortic regurgitation, coronary anomalies, MAPCAs, PDA and side of the aortic arch. Still frame from an angiogram with radiocontrast dye injected using a pigtail catheter kept in the right brachiocephalic artery, showing major aortopulmonary collateral artery arising from the right internal mammary artery. MAPCAs are seen in severe forms of tetralogy of Fallot and pulmonary atresia. When the lungs are supplied by multiple MAPCAs, They are unifocalized prior to definitive surgical repair of tetralogy of Fallot. Connecting the distal end of MAPCAs to a single vessel is known as unifocalization. Collaterals to the pulmonary arterial branches can also arise from the bronchial arteries within the lungs. Hilar collaterals can also occur in pulmonary atresia.